Hi, this is Brian Kim. I want to share with you this case of a white swollen cataract. And this is interesting. I've never had a posterior capsule rupture using the polymer tip during INA. And so you'll see this actually for the very first time when I'm doing this cataract removal. And everything was going so routine, everything seemed to be fine. And so I really don't blame the polymer tip in this case, but you'll see what happens here. So again, this is the white cataract. You can see how swollen and white it is. I'm using cotton tip to steady the eye, using a corneal marker, which will help me to center and size the rexus. I'm making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral lidocaine, and then some intracameral air, and then I'm going to inject some intracameral epinephrine, as well as now the trypan blue. And so the trypan blue I'm painting on the surface and not being too aggressive with it here, just painting. This canyon is a little weird, and so you saw it just kind of shot out. There's a little bit of resistance with the plunger as I push that cannula. So then I'm injecting some dispersive viscoelastic to fill the chamber and coat the cornea. And this is the Tri-Planar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then enter. So far everything's going great. I push some more viscoelastic in, and this is the puncture technique using a 25 or 27 gauge needle. I puncture the center, and then I start to aspirate. Thankfully, I don't see a big plume of any sort, so I don't think this is intumescent. But just looking at the lens, it did look like an intumescent and swollen lens. So I'm using that needle to just push and create a little bit of a tear. And now these are my rexus forceps to go ahead and go around circumferentially. And thankfully, it's not trying to radialize very much here, but I'm being very mindful of the fact that this could suddenly become like an Argentine flag here. But so far, so good. The rexus is not running out. So it's not really a swollen intumescent lens. Able to complete the rexus here, burp some viscoelastic out. And this is the Capsular Fornix Hydrodissection technique. I place the cannula under the rexus edge contra-incisionally, point the tip down, get a nice wave. Of course, you can't see it because the lens is so white. I start to free up the anterior capsule on the left side, and as I do that, you can see the lens spins quite nicely. Whenever you have these white lenses, the cortical material is so fluffy, there's no real adherence of the lens material to the bag, so it's pretty easy to rotate and spin the lens in these cases. So I'm putting some irrigation fluid on the cornea, adjusting my sleeve, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material here, placing the chopper underneath the rexus edge contra-incisionally, the phaco tip vertically sub-incisionally, bringing the instruments together slowly and carefully, fracturing the lens completely in half. That is the double chop maneuver. And then I go ahead and place the chopper underneath the rexus edge underneath the right heminucleus, pulling it centrally toward the phaco tip. Since the phaco tip is already deep in the bag, I'm able to fracture the right heminucleus, placing the chopper around the first quadrant, crushing the lens between the instruments, lifting it up with some vacuum, and then I'm starting to crush the lens pieces between the instruments some more, and then emulsifying the lens piece. You can tell there's quite a bit of substance to the lens. This is not just a soft white cataract, this is a fairly dense cataract. Placing the chopper around that second quadrant, positioning the instruments around the lens piece and then crushing it with mechanical forces, spreading the lens pieces, grabbing that one piece with some vacuum, hooking the chopper around it, crushing the lens between the instruments, and then emulsifying the lens pieces. So you can see there's not much cortex in this dense white cataract. I turn the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally toward the phaco tip. The phaco tip is fairly deep in the bag. It bisects that lens in half, placing the chopper around the third quadrant, doing the same maneuver, crushing the lens between the instruments, and then grabbing the lens piece with some vacuum, crushing the lens piece between the instruments, and then emulsifying the lens pieces. So far so good. Again, everything was going really routinely. This is a pretty dense white cataract, but thankfully I'm able to use mechanical fracturing, double chop, cross chop, and very carefully and systematically I'm able to fracture the lens pieces into smaller pieces, and then using pulses of ultrasonic energy and vacuum. In this way, the chamber is nice and stable. The posterior capsule has not come up at all with any of the maneuvers. So now the entire lens has been removed and there's some remnants here. I'm removing the remnants. So I take the chopper out, push BSS in, take the phaco tip out, and go in with the ironing handpiece. And you can see there's just a bunch of small wispy pieces of Cortex there. I'm very carefully, with foot pedal modulation, removing the Cortex. I don't really go pedal to the metal here. Oftentimes with these lenses, there is some zonulopathy. So I'm using foot pedal control to peel off the Cortex. You can see the posterior capsule has so much very fine, lens material. It's kind of annoying, wispy lens material. So I'll have to go after that at some point. Some of that could be just capsule fibrosis as well. So I'm peeling and look what happens here. I'm thinking, okay, I'm getting some Cortex, that looks great. And then you can see this wrinkle, and that wrinkle is actually a posterior capsule defect. And so again, obviously, I don't think there's any sharp edges to the polymer tip. I don't think it was one of those things. I just think that the suction of the vacuum and a focal area of weak bag right in that area just caused it to tear. And so I do have about a quadrant of posterior capsule rupture. Before I come out, I push some cohesive viscoelastic to fill the bag and make sure that everything's tamponaded away. And again, there's not much Cortex in the bag anyways. Most of that stuff is just PC fibrosis. So I go ahead and widen the incision, and I decided to go with a 3-piece lens. I was going to go with a 3-piece lens anyways because, as you know, I like to put 3-piece lenses in these dense lenses because I know they tend to be associated with zonulopathy. So the lens goes into the sulcus. Dialing the trailing haptic into the sulcus here. And I'm just going to do a optic capture technique. And so again, no vitreous during this entire case. Everything has gone well. I go in with the ironing handpiece, activate irrigation, go underneath the lens, removing the viscoelastic from underneath the lens, just being mindful not to invite any vitreous. So that's a really quick removal of the viscoelastic, and then I come out. And so you can see I'm just gently tucking each side of the optic underneath the rexus edge. And so now we are in optic capture configuration. And then I go ahead to go to visco mode, removing all the viscoelastic from the anterior chamber. And because it is an optic capture configuration, it's a really nice tight fit. You can see the almond shape of the capsulotomy opening. And it's unlikely that there's going to be any vitreous that's going to wrap around and come into the anterior segment. But I'm quickly transitioning and hydrating my incision so that the chamber doesn't collapse too much. Hydrating the main incision here, and then hydrating my wounds. You can see that almond-shaped capsulotomy opening, and that is, again, indicating the optic capture configuration. And I chose in the bag lens power for this patient. Go ahead and hydrate my incisions. Again, I did not encounter any vitreous at all during the entire procedure. You can see that focal defect on the left side in the posterior capsule. but this case otherwise went quite uneventfully. And it goes to show, I don't think that the polymer tip caused a posterior capsule rupture, but when you're dealing with these white cataracts, you just don't know what's going on. Maybe the patient had trauma. And even though I'm using that polymer tip, as I was going and peeling the cortex within the Capsular Fornix, you saw that the must have been a weak area in the posterior capsule and it just tore. And so you never want to come straight out. You'll invite vitreous into the anterior chamber. As the chamber collapses, you want to keep the fluid going and then do a quick switch from the fluid to viscoelastic, fill the bag with viscoelastic, tamponading any potential vitreous trying to come forward, and then go ahead and place that lens, the three-piece lens, into sulcus, removing the viscoelastic from the bag, and then doing the optic capture. Some people might not have removed the viscoelastic from the bag, but for me, I felt like it was worth doing. You don't want to leave the viscoelastic trapped in the bag. And so I went ahead and did it that way. And fortunately, everything went well. And again, because I had a really nice size rexus, I knew that it was going to be a pretty tight optic capture configuration, as you saw with the almond-shaped capsulotomy opening. And this patient did great. So I hope this was helpful to you. And I thank you for your attention.